Ready? What do I do now?
All right, you're live.
Where's the pictures? Hey, this is Elliot Fishman. Welcome to Facebook Live, and I hope that this is going to give you the right pictures. I don't know, what do I have here? Let me see. Oh, look at that. We have this thing is showing up.
Okay, cancel.
Okay.
Now let's go to.
Hey guys, we're just having a little technical issues here.
Yeah, try clicking this.
No,
Yeah.
it's broadcasting this. That's why.
Yeah, you need to click this.
Okay.
So, should go to PowerPoint. No, here. And then Facebook quiz. I bet. Okay.
All right, we're here. Facebook quiz, unbelievable. Hi guys, sorry about that. I am telling you, between Lily and I, we almost can get things correct. Facebook Live, we love Facebook Live, and this is Facebook Live on a Facebook quiz. This is a YouTube quiz, so forget that. All right, we're just gonna tell you that we're glad we're here. I hope we can edit this, is all I could say. So I'm gonna start right now, so when people for the next billion years look at this, they think we're on the money. So I'm gonna start now, okay? Hi, this is Elliot Fishman. Welcome to YouTube Live. I got a dozen cases for you. We're gonna go fast. You gotta think, and then we'll get them right. Okay, incidental finding on a calcium score. What do you see? You see some calcifications in the left ventricle. Is that like an old infarct? Good thought. What else could it be? It's not a foreign body. Maybe it's a tumor. Well, look at this. You give IV contrast and there's a mass in the left ventricle. What could it be? It could be a tumor, it could be a thrombus. Thrombus can calcify, but then they're old thrombi. LV right in the middle? I don't know about that. Thrombi more common right atrium, maybe left atrium. But left ventricle? I don't like it. So now you gotta say a tumor. What can you get? You can get Mets, renal cell, sarcomas, lymphoma, but usually it involves the pericardium and the myocardium. What else? So a filling defect. Well, you would say if this was in the patient's left atrium, I would say left atrial myxoma. Right atrium, I say myxoma as well. Myxomas are most commonly in the atrium, most commonly in the patient's left atrium. But this is not. This is the left ventricle. What am I dealing with? Here's another view of that. Really good question. What am I dealing with? A mass with faint calcification. Remember we said myxomas do calcify. You go through a whole differential, but there it is, left ventricle myxoma. What a great case. I almost never see that. Okay, next patient has a cough. What's going on here? Is this an impacted steak particle in the esophagus? Could be. Is this reflux? Is this achalasia? Look at the sagittal view. It's an outpouching, so it's not the whole esophagus like achalasia. The rest of the esophagus is not dilated at all. Location. What looks like a pouch compressing the esophagus? Show nicely on the views in that location. What is it? You know. It's a Zenker's diverticulum. What a great case of a Zenker's diverticulum. Again, something to be aware of. Okay, let's try again. Another patient with a cough. Is this another Zenker's diverticulum? Would I be so tricky to give you a gigantic Zenker's diverticulum? It could be obstructed esophagus, it could be reflux. But look at the coronal and sagittal. Look how dilated the esophagus is on axials and on coronals and sagittals. And the transition you can see in the coronal and sag very well is at the GE junction. Now, could this be a mass at the GE junction? But I don't see a mass. And usually patients will present earlier with a mass. What gives you such a big esophagus? Scleroderma gives you a big esophagus, but not this big. And there's so much food matter, it's like it's storing food in there. When I see that appearance, sometimes the patients present with widened mediastinum on chest x-ray. This is a classic example. Everyone know the answer? Boom, achalasia. What a great example of achalasia. Okay, another patient. This was a burn patient 2 weeks post-surgery. We did a CT scan looking for an abscess. Patient has a G-tube in place. I'm going to focus on the kidneys. What about the kidneys? Well, what bothers me, this is a good injection, but the cortical medullary differentiation is really poor. What gives you poor cortical medullary differentiation? One is the patient's hypotensive. You want to look at the adrenals. One is the patient has poor renal function for many things, including obstruction. I don't see obstruction. I don't see stones. All I see is lack of good cortical medullary differentiation. And here it is nicely on the coronal view. Big pericardial effusion. Also, there's a fluid collection, excuse me, in the buttocks on the left. What could this be? Again, remember that burn thing? Patients with big-time trauma with muscle injury or burns, you get rhabdomyolysis, which can lead to renal failure. When you see lack of cortical medullary differentiation, you think obstruction, but that usually is persistent. You think of hypotension, you think of rhabdomyolysis, you think of contrast-induced nephropathy, sometimes due to chemotherapy. Rhabdomyolysis, again, clinical syndrome caused by damage to skeletal muscle and release of its breakdown product into the circulation, which can be followed by acute kidney injury as a severe complication. So really a wonderful, wonderful example. Something to think about if you're examining a patient who's had trauma a week earlier, a few days earlier, or even a presentation, and the kidneys don't look right. Think about this possibility. Very, very, very important. Okay, let's stick with the kidney. This looks like a mass in the adrenal or the kidney. The adrenal, okay, looks all right. And I'm telling you, it's the kidney with hematuria. I would just say a big renal cell carcinoma, not very vascular, clear cell versus papillary. I guess infiltration, maybe I should think about lymphoma. Contralateral kidney looks all right. I'm thinking tumor all the way. Here it is in the coronal view. A little bit of cortex remains. But what else should you think about? Well, if it's not going to be tumor, you can see I'm making you think not tumor, infection. What kind of infection? I don't see a stone obstructing, and then you have big calyces that are dilated. Doesn't quite look like that, but it kind of looks like calyces on the coronal view. What am I thinking about? Look how small the vessels are to the right kidney, which means it's been there for a while because the vessels are really tiny. Compare the right renal artery to the left. And what are we dealing with? We're dealing with infection. Now, I have to admit, if I gave you a big Staghorn calculus centrally, you'd make the diagnosis. But there are no stones present of note. But this was XGP on path. And again, the presentation was renal cell. Patient had vague symptoms. Sometimes you get fever from tumor. It kind of looked like a tumor. There's no doubt about it. A great example and a typical example of XGP. Another patient, back pain. What is this mass in the right pararenal space? Very vascular. Now, if you look on the left side, the adrenal looks good, but the spleen rotates posteriorly, as does the bowel. And yes, you could say maybe the patient has a pelvic kidney, but that's a more classic appearance, in this case rather, of a left nephrectomy, which means the patient, I'm showing you a quiz case, the patient had a left nephrectomy, the bowel falls back, spleen rotates, and now you have a MET to the pararenal space. Metastasis of pararenal space, renal cell is great. And by the way, you see the pancreas. There's a lesion right in the body of the pancreas near the head. Metastatic renal cell to pancreas and to pararenal space on the right. What else could you think about? Lymphoma can do this. Metastatic melanoma could do this. A number of different lung cancer can do this. So again, good differential. And this was, of course, metastatic renal cell carcinoma to the pararenal space as well as to the pancreas. And yes, by the way, excretory phase imaging, you can see how this washes out. You can see how the pancreatic lesion is very difficult to find. When we were early phase, it was obvious. Again, to remind you, when you're scanning patients with renal cell, you got to do early phase imaging if you want to be able to see a lot of the metastasis. So just a really, really, really good case. Okay, what now? Adrenal lesion, vascular. What is this? When you think of adrenal lesion, you close your eyes, you say pheo. You think about metastatic renal cell. And this lesion, again, very vascular. So what else could it be? ACC, a very small ACC, adrenal cortical carcinoma, primary. A thought. But what if I told you it's a benign lesion? Well, we've had a few of these, and those are adrenal hemangiomas. Look how the lesion fills in. It fills in like it's a hepatic hemangioma. So a vascular adrenal lesion, think pheo, always. Think metastasis. Yes, you could think about a primary adrenal cortical carcinoma, though usually the whole thing's not vascular, but also think hemangioma. It's rare, but it does occur. It's a great possible diagnosis. Okay, what else? Back pain. Speaking about the adrenal, large mass, it's solid. It's not really enhancing much on the arterial phase imaging, though it does enhance on the delayed and venous phase, and you can see central necrosis. So when you look at the tumor, there's the central necrosis, there's the pushing of the kidney down. What could this be? Well, you go through. Could it be a pheo? It should be more vascular. Could it be a met? Absolutely. Could it be an atypical adenoma? I guess it's a chance. We've seen cases like that, but I don't call things that are this large adenomas. So you've got to think about a primary adrenal cortical carcinoma. They can be very vascular or they can be hypovascular. This one, you'll watch the images, is just not a lot of vascularity. It doesn't look like a pheo. It doesn't look like I showed you hemangioma. It doesn't look like anything else. What else could this be? Well, this ended up being a primary adrenal cortical carcinoma. They can be vascular, they may not be vascular. They can have necrosis, they can have calcification, they can have occasionally fat. Can be a very important diagnosis to make. Again, you prefer not to biopsy an adrenal cortical carcinoma because the only way of curing a patient is resection, taking out all the nodes. So you don't even want to do this laparoscopically. It's an open procedure. Very, very important. All right, what about this? Get the pancreas. We're getting near the end. Big mass, the first thing you say, pancreatic mass, next case. But the lesion is very well defined. There is a pancreatic duct dilated, but this is not the appearance of adenocarcinoma. It's not the appearance of a neuroendocrine tumor. The neuroendocrines at times may not be very vascular, but this is really hypovascular, a little bit of necrosis centrally, kind of looks like the adrenal from a moment ago. What could this be? Now, could it be a duodenal tumor, like a GIST tumor faking you out? It's a possibility, unlikely. Could it be a paraganglioma? Can occur nearby, but paragangliomas are very, very vascular. It's not that. What could this be? Well, when I called on one of our faculty, they said, I once saw a case of a peripancreatic mass that was a schwannoma. And this indeed was a peripancreatic schwannoma. What a great case. And for the patient, it was great because you can cure the patient. Resecting that, it's not going to be an adenocarcinoma of the pancreas. So really, really good diagnosis, and that indeed is what it was. Okay, sticking with the pancreas, another case. Incidental finding. Is this lesion near the pancreas or from the pancreas? Near the pancreas, it could be a mesenteric cyst, could be a lymphangioma. Near the stomach, could it be a GIST tumor? If it's coming from the pancreas, you look at it here, it looks like it's coming off the surface of the pancreas. Cystic low density. MCNs are in the gland. IPMNs are in the gland. Serous adenomas are more in the gland. This is touching the gland, basically, coming off the gland, basically being exophytic. That's and it's low density. What's the diagnosis? Ding, 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 lymphoepithelial cyst. Benign lesions. You can leave them alone if you find them. Looks like it's abutting the gland or coming off the gland. Sometimes it's a bit deeper in the gland. A very important diagnosis. You don't want to biopsy these because patients often will get severe pancreatitis. If you're thinking about it and you want to remove it, just go and remove it, but do not biopsy it. Okay, again, pancreas. Since we had the tail, here's another tail lesion. Cystic lesion, calcifications, and solid nodules. What am I dealing with here? What are these nodules? What am I dealing with? What's going on here? Doesn't look like an adenocarcinoma. The calcifications don't work. Could be a neuroendocrine tumor. They can be hypovascular and commonly calcify. Serous adenoma doesn't look like it with the nodules. Mucinous cystic tumor, it's a possibility They're usually in the body, but can be in the tail. They can calcify. They can have nodularity because they have high-grade dysplasia at times or malignancy. So MCN is a good thought. If I told you the patient was 20, I'm not saying she is 20, but if I told you she was 20, you would then say also SPEN tumors. When you look at calcifications around the periphery particularly, but coarse calcifications in a cystic mass with solid nodule component, the diagnosis of da-da-da-da-da, drum roll, boom, 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 a SPEN tumor is really a good one. Cystic lesion, mural nodules, calcification, some enhancement, excellent for a SPEN tumor. What a great, great, great case. And let me now give you the last case. Again, sticking with the tail of the pancreas, left upper quadrant pain. There's a mass in the tail of the pancreas. At first glance, it looks like a neuroendocrine tumor. It is cystic. And if you look at this, the pancreatic duct is dilated. Looks a little bit like the prior case with had dilatation. And the patient previously had a serous cystadenoma. But you got to worry about malignancy of some type. What indeed could this be? And here it is again. Now you see the dilated duct. But as you look at this cystic mass, you really realize as you look more and more carefully, take out the magnifying glass, take out the Hubble Space Telescope and look carefully. Looks like lots of cystic lesions. And they look like a Swiss cheese pattern. Yes, you say serous cystadenomas do not obstruct the duct. They can. Serous cystadenomas can calcify, particularly centrally. Serous cystadenomas, often the cysts are best seen on the venous phase imaging. So as we go to venous phase imaging, we see that cystic lesion, and that's a serous cystadenoma. That's a great case. And with that, I'm going to say that's the end. I hope everyone had a great time answering the questions, thinking about the questions. Yes, I may have gone fast. Someone says, maybe you went too fast. I need more time to think. Well, watch it again. Watch it on slow motion. Maybe the answers will change. I need to get done because I got to read some more cases just like you. Anyway, all kidding aside, I hope you have a great day. And as soon as I figure out how to end this, I promise you I will. So from all of us at CTisus, have a great day. And you may or not see Lily's hand. Bye, guys.